Good morning, everyone. My name is Dr. Jason Wong. I'm a physician from the Neurology Unit in Sarawak General Hospital. I'm very grateful to be able to be involved in this edition's Motor Neuron Disease Beyond Borders. Our main agenda today is a case presentation sharing session. From the Neurology Unit, we would like to take you through a patient's diagnostic odyssey of motor neuron disease through to the multiple facets of multidisciplinary team management. To start, I would just like to spend a slide or two on motor neuron disease introduction. Motor neuron disease are a group of neurodegenerative disorders that affects motor neurons in the brain and spine to progressively lose this function. Motor neurons are a type of nerve cells that helps control voluntary muscles of the body, and this can be divided into upper motor neuron and lower motor neuron. This is important as dysfunction of these will manifest as clinical signs recognizable on examination. Diagnosis of motor neuron disease is made on clinical grounds by an accurate history and as well as a physical examination. There are various criteria available to help us reach a diagnosis with various levels of confidence. However, there are still no specific tests available to confirm the diagnosis. The cause of this disease is still not well established, but we do know that genetics play an important role, and this opens up therapeutic windows for researchers to explore, and hopefully we can have a treatment available in the near future. The mean age of onset is 5th to 6th decade. However, we do have to keep in mind that motor neuron disease may present at any age, and the progression is generally variable, and it will depend on the type of motor neuron disease. We do know that the most common form of motor neuron disease is actually ALS, which is made famous by this ice bucket challenge back in 2014. So I'm sure everyone has heard of the ice bucket challenge, and this challenge sort of viraled out and brought a lot of publicity as well as funding to the ALS research scene. There is no cure for motor neuron disease, unfortunately, and the mainstay of treatments remains symptomatic as well as improving the quality of life of the patients with motor neuron disease. So, like I mentioned, there is a familial form, and however, the more common form is the sporadic form. Sorry, I made an error there. The 10% is supposed to signify the familial form of the disease. So the classic sporadic ALS, I mentioned this in the previous slide, the most common onset, age of onset is the 5th to 6th decade. And usually, the presentation is usually manifested in weakness in the limbs. So from this these various diagrams, you can see that there's this spinal onset, which is synonymous with this limb onset. So 70% of patients will start off with weakness from the extremities. There's a subgroup of patients that have weakness started off in the bulbar segment. And some of them, the weakness remain limited in the bulbar segment. Otherwise, they will manifest as progressive bulbar palsies. And there are other forms of motor neuron disease. I'm sure you might have come across this before. So if you get predominantly just lower motor neuron involvement, this is otherwise known as progressive muscular atrophy, whereas on the other spectrum, if you get predominantly upper motor neuron findings only, this is otherwise termed as primary lateral sclerosis. There are other limited forms or focal forms of motor neuron disease as well. And these are stated here, such as flail arm syndrome or flail leg syndrome. So next, just like to move on to the case sharing session. So our patient is Mr. A.A. He's a 59-year-old gentleman of Malay ethnicity. He used to work as a police assistant officer, and he retired at the age of 55. Prior to this, he only had comorbid hypertension. He was quite well and healthy up to his retirement age, and even up to 1 to 2 years post-retirement. He does not have any bad habits such as smoking or alcohol consumption. He's happily married with 5 children. His wife used to work as a nurse. He comes from a big family with 10 siblings. And the only family history of note is that his father had GI malignancy, and this was one of the concerns at the time. So he was first referred to our clinic back in the middle of 2019, and he was actually referred to our clinic by his neighbor who happened to be a doctor from the government, from our hospital. Mr. A had actually experienced symptoms 1 year preceding his clinic visit. So he started off with progressive bilateral loading weakness, and he specifically mentioned that he's walked shorter distances than before. He experienced muscle cramping. He had reduced stamina. And after a year of experiencing the symptoms, his weakness sort of progressed up to his upper limbs, mainly involving the distal hand muscles first, affecting fine motor function of his hands. And his weakness further progressed, affecting his swallowing as well as his voice. And all this constellation of weakness eventually affected his nutrition, and he had a significant loss of weight of over 20 kilos. So he used to be at a good weight of 70 kilos. However, when he came to see us in the clinic, he was less than 50 kilos. So on general examination, we could see that he was quite malnourished. You know, he was cachexic. Examination of his cranial nerves, otherwise the upper cranial nerves were quite normal, including normal eye movements. There was no traces of fatigability present to suggest anything such as possibility of a neural muscle junction disorder. His speech was quite dysarthric and sounded of a nasal quality. His tongue was wasted, and there were fasciculations at rest evident. The jaw jerk was brisk, so there were both upper motor and lower motor neurons findings straight up on clinical examination. His cognition was otherwise normal, and systemic examination was also unremarkable considering that one of our differentials was malignancy due to his positive family history. Moving on to his neurological examination, well, straight up from inspection, we could see that from the upper limbs, he had claw-like finger deformities. He had wasting of the small muscles of the hand, and the wasting preferentially affected the thenar muscle groups, giving it a split hand appearance. There were wasting of the small muscles of the interossei. So he had guttering of the hands as well. His forearm muscles were wasted. However, it surprisingly spared the brachioradialis muscle, and there was no myotonia. While in the lower limbs, while he was on a wheelchair, he had generalized wasting involving the quadriceps as well as the tibialis anterior, and he had fasciculations in these wasted muscles. And he had a fair amount of foot drop as well. So these are the pictures depicting that he had wasting of the tongue, he had wasting of the forearm muscles, he had a claw-like appearance. You can see that his thenar muscles is very much atrophied. This photo again shows the closer up picture. There's forearm wasting, claw-like finger deformity, wasting of the thenar muscles. And this shows also guttering over the small muscles of the hand. In the lower limbs, you can see that there is significant quadriceps wasting. I did not take a video, but there were some occasional fasciculations there as well. And there was some foot drop on the lower distal extremities as well. So on the examination proper, his tone was still quite fairly normal in the upper and lower limbs. However, on assessment of his power, you can see that there was quite a distal predominant muscle weakness, but mainly affecting the elbow movements of extension and flexion, wrist extension and flexion with a power of 4/5, and the fine motor movements, including the finger movements, all had muscle reduced up to 2/5. Despite his wasted muscles, he had preservation of his reflexes in his biceps, triceps, as well as brachioradialis muscles in both sides. And he he had a negative Hoffman's test. Down to his lower limb, well, his lower limb muscles were quite, I would say, more affected than his upper limb muscles. From his hip, knee muscles, he already experienced muscle weakness with power MRC grade power of 4/5, and down to his ankle, he experienced quite a significant weakness over his ankle movements, giving it quite like a flare foot appearance. Again, despite his significant muscle wasting, his reflexes were quite preserved in his knees as well as ankles. He did not have any clonus, and his plantars was downgoing. So his motor examination was that his sensory examination were otherwise quite unremarkable. So dorsal column as well as spinal thalamic tracts were all normal, and there was no any impairment present. So based on his physical examination findings, we concluded he had mixed upper and lower motor neuron findings over the bulbar, bilateral upper and lower limbs with a normal sensation. So we localized his pathology to likely an anterior horn cell disease. So this is just some pictures and videos of other patients with motor neuron disease. Again, this lady had motor neuron disease with a split hand appearance. You can see, well, she had quite an early form of the disease. You can see that it started to have a split hand appearance with a thenar eminence wasting. This video I like to show that there's quite marked presence of fasciculation over the left triceps muscle. Actually, it's occurring both sides, and you can see that there is some forearm wasting there as well. This patient had generalized wasting of the tongue and some fasciculations. And this last video, well, this patient actually had polymini myoclonus. It looks like the fingers are, they say, a piano playing fingers, which she actually experienced involuntary movements over her fingers. It's a hyperkinetic movement disorder that is closely linked to anterior horn cell diseases such as motor neuron disease. So the differentials, well, based on the neural axis categorization, well, we had a long list of possible differentials, some very rare causes, but however, there are some quite common diseases also that we needed to think about, such as neuromuscular junction disorders like myasthenia gravis, considering that he had bulbar involvement as well. Okay, but like I mentioned, he did not have any fatigability present on his examination, and his eye movements were quite normal. Okay, other things that we wanted to particularly rule out were things like myopathy, okay, and as well as other rare causes of motor nerves, so such as multifocal motor neuropathy. Okay, it's an exhaustive list. And you can look through it in your own time if you are interested. Okay, so subsequently, our investigation took us to some blood tests, and she had otherwise quite a normal blood examination and workup, full blood count, a renal panel as well as a liver panel, and the muscle enzymes were all normal. His thyroid function was normal as well, and his biohazard with a Hep B, Hep C, and a HIV status were all non-reactive. So subsequently, we progressed on with neural imaging with MRI brain and cervical spine, and this too was quite normal. There was no significant abnormality, and there was no evidence of any cord compression or myelopathy. So other investigations were considering he had a positive family history of GI malignancy, and OGTS was done, and he only had and this was negative for any mitotic lesions. He had reduced stamina, so we did an echo for him, and he had a structurally normal heart. Well, his lung function tests were otherwise quite affected. He did have a restrictive pattern of weakness on the lung function test, and Dr. Young from respiratory team will elaborate more on this in her talk later. So subsequently, we moved on to a nerve conduction study, and her nerve conduction study did show that he had reduced compound muscle action potential in his motor nerves, which is quite which can be seen in motor neuron disease, especially in quite advanced stages where you get axonal loss of the motor neurons. There are no demyelinating features, and sensory studies were quite normal. We did a EMG for the patient. For those that are unfamiliar with EMG, well, I separate out the muscles into 4 groups based on these color codes. So there's this bulbar group of muscles, cervical group of muscles, lumbar group of muscles, as well as thoracic group of muscles. And what we were looking at is we're looking at mainly 2 things. The first part is we were looking for spontaneous activity. You can see that there are 1+. These are all indicating that there are spontaneous activities in the bulbar segment, in the cervical segment, in the lumbar segment, as well as the thoracic segment. And all these indicates that there is ongoing active denervation in all 4 regions of the tested muscle groups. The second part was to look at the muscle unit action potential, whether there are any changes to it. And that too also showed that there are some changes suggestive of chronic neurogenic changes in 3 out of the 4 body regions. So again, this shows that there is chronic denervation changes in these regions. So this is important as the latest criteria do state that you need to have both active and chronic denervation changes to support your diagnosis of MND. So, to conclude, this patient had clinical upper and lower motor neuron pathology. He had a normal sensation. He had EMG as well as nerve conduction studies shows active, ongoing, as well as chronic denervation in 4 of the body regions. He had neuroimaging to exclude other differentials. So we concluded that this patient had motor neuron disease of a clinical definite ALS subtype. Now, this clinical definite ALS is essentially from this criteria from the L-Escorial diagnostic criteria, where you base this function of motor neurons on body regions. So again, like before this, I mentioned that there are 4 body regions that we look at, and depending on how many body regions are affected, we diagnose these patients with increasing certainty. So if there are more than 3 regions involved, you get clinical definite ALS. If you get 2 regions, you have probable ALS, and if you have only 1 region, you get possible ALS. So essentially, this classification system is sort of ambiguous to clinicians as well as to patients, whether they have true ALS or not. And this has also affected patients getting into clinical trials. So besides the traditional L-Escorial as well as the Awaji criteria, where they divided into regions and diagnosed them based on involvement and decide on the certainty of their diagnosis, there is a new criteria that has been proposed, otherwise known as the Gold Coast criteria, which I would like to introduce on. So this paper is actually by Professor Matthew Kernan's group from Australia, and they do meet up, and this was back in 2019, and they did come up with this Gold Coast criteria. Essentially, there's only three criteria that needs to be met. The first one, progressive motor impairment, documented by a history or clinical assessment, preceded by a normal motor function, and presence of upper and lower motor neuron dysfunction in at least 1 body region. So now you only need one body region to diagnose the patient as ALS, whereas previously involvement of only one region will only classify you as possible ALS. So, so all these three criteria need to be met for you to be diagnosed to have LS. So this new criteria actually is binary. You either have LS or you do not have it. They've removed the label definitive, probable, and possible. Okay, just some footnotes that I would like to highlight. Like I mentioned, upper motor neuron dysfunction can be highlighted by the fact that if you have a normal reflex in a clinically weak and wasted muscle, that does count as an upper motor neuron sign. Okay, and then lower motor neuron dysfunction, you must have both weakness and muscle wasting. Okay, to qualify this as a lower motor neuron dysfunction. And like I was telling you earlier regarding the EMG abnormalities, you must include both evidence of chronic neurogenic change and evidence of ongoing denervation. Okay, so again, this is just emphasizes the same point that I was making. You need to meet these three criteria, and you only need one body region involved currently for you to diagnose someone as ALS. So essentially, this Gold Cross criteria is mainly developed to facilitate earlier diagnosis and remove the ambiguity surrounding the previous classification. And in turn, that this will hope to improve patient access to clinical trials. So now moving back to the care pathway for motor neuron disease in a hospital setting. So once a patient has been diagnosed with motor neuron disease, they get referred to the multidisciplinary team clinic here, where they will receive various subspecialty input as well as allied health care. So a word on multidisciplinary team approach. So both the American Academy of Neurology as well as the European Federation of Neurological Sciences recommend MDT care. So essentially this will benefit the patients in improving survival, reducing medical complications, as well as improving the quality of life of not only patients, but also their caregivers. Well, in our hospital, we have the MDT clinic every month, and this is mainly hosted by the rehab clinic. I will introduce the support groups in a later slide. So the multidisciplinary group involves a core team of doctors and as well as allied health professionals, such as the neurologists, the rehab care physician, palliative care physician, the physiotherapist, speech and language therapist, occupational therapist, and towards the later stages, maybe the respiratory specialist as well as the palliative care specialist. The outer rim of services, unfortunately, in our setting, we have not expand our services to involve these available facets. However, this is something that which provides a very comprehensive care. Besides this, I also want to emphasize that not only does this core team of doctors is important, however, I do think that the most important person in managing a patient with ALS is actually the caregiver. So moving back to Mr. A's progression disease timeline. So he first started having symptoms back in 2018, and he first started, like I mentioned, he started having lower limb weakness. However, at that time, he was still able to function independently and still able to walk short distances. However, the following year, he developed progressive weakness involving his upper limbs and subsequently bulbar involvement. So he had started having difficulty swallowing as well as voice changes. So it was then when he was referred to outside, and we admitted the patient and got his evaluation done and subsequently diagnosed him with motor neuron disease. And at the same time, we started him on riluzole 50 mg PD. And over the last 2 years, unfortunately, he has progressed quite a fair bit. His nutritional status is quite affected. He had marked muscle bulk loss and also weight loss, and an NG tube was just not cutting it for him anymore. It affected his NIV usage as well. So eventually he needed a PEG tube being inserted for him. And over the past year, well, eventually his fell foot has robbed him of his independency, and he's now mostly wheelchair bound. He's getting more and more fatigue, and we noted that his breathing is actually more and more effortful. Subsequent clinics has noted that he is becoming very tachypnic, and this is the main focus of our talk, and this will be mainly covered by Dr. Chai as well as Dr. Yong in subsequent talks. There are other medications that tackle the symptoms of motor neuron disease, such as spasticity, pain, fatigue, muscle cramps, as well as in some patients they get excessive secretions of saliva. And also a part that we should also we hope to involve our psychiatry colleagues in the future, and unfortunately this patient we did not assess much on his psychiatry aspect. So just a slide on the medications in ALS. These are the two FDA approved medications. They were approved almost 20 years apart. Well, the first drug, well, I'm sure everyone has heard of it, is otherwise known as Riluzole, was approved back in 1995. Its mechanism of action, well, it inhibits glutamate excitotoxicity, and it has other pleiotropic neuroprotective actions as well. And on average, well, it modestly prolongs survival up to 3 months. And well, this drug is not available in the Blue Book in Malaysia, so at the moment it needs KBK application, and most of our patients will need to self-purchase it. It costs us about 3,000 a month. The new, the relatively new kid on the block is otherwise edaravone, which was approved in 2017, mainly based on Japanese studies, and the mechanism of action is, well, it's an antioxidant and a free radical scavenger. The studies otherwise mainly shows that they improve function, not so much of the long-term survival yet. I'm unaware of any recent more studies, and well, it is an intravenous route of administration of this drug, and the costs are significantly higher. And so the support groups and resources, so an important part of the facet of MDT care is to introduce patients to support groups as well. And these are the platforms available for patients. MND Malaysia is an NGO association that provides a support network for the patients as well as the caregivers. And they have a lot of resources available on their website. So I do recommend that if you're interested and if you're able to, do go to their website and explore. This resource guide on frequent asked question on ALS was produced by Dr. Sheila as well as Dr. Law Yi Chin from UMMC. And I do recommend you have a look at this. It is in Bahasa Malaysia, so the English version is yet to be released. So other resources available on the website, well, there's this 11-chapter series with very relevant topics regarding ALS and the facets of ALS. So we do recommend the patients with ALS to look through these if they need to. And with that, I'd like to end my talk.
morning, everyone. I'm Chai, rehab medicine physician and lecturer in Sarawak General Hospital and University of Malaysia, Sarawak Unimas. MND Beyond Border for the invitation for the MND cash sharing for Sarawak for the land of Hornbill. So I'm going to present the rehab part of our case. So for my part, I also asked to introduce some exotic animals of Sarawak. So these are exotic Hornbill and these are exotic orangutan in Sarawak. I would like to thank Dr. Lim from MND Beyond Border and Dr. Leong, Head of Department of Rehab Medicine in Sarawak General Hospital for coordinating this case sharing. I would like to thank the previous lecturers and professors in UM who are experts in MND for the knowledge and skills in MND management and rehab. I would like to thank my Sarawak MND multidisciplinary team for the assistance for this case sharing. So I'd like to introduce this my hometown, we are from Kuching, Sarawak here. So this is Sarawak General Hospital and University of Malaysia, Sarawak, which I'm currently working at. So Kuching is at the southern part of Sarawak. So this jungle of Borneo in our Sarawak National Park, where you can find exotic animals like hornbill and orangutan. And from jungle of Borneo, then to the modern city of Kuching, you can see the beautiful building. And this in Kuching, this is where the Sarawak General Hospital is located at. So our pulse from this case is following up for his motor neuron disease treatment and rehab in Sarawak. So this University Malaysia Sarawak or UNIMAS, a public university in Sarawak. So this is where I'm currently working in for the medical academic duty like teaching and research. So this is our case, Mr. A, 59 years old gentleman, is diagnosed ALS since 2019, which the neuro team already presented just now. So he's currently at stage 5 of ALS. So he was stage 3 during the diagnosis and currently progressed to stage 5. So there are actually 6 stages of ALS. From 1 to 3 is the patient still can ambulatory, and 4 to 6 is non-ambulatory. And 1 to 3 is the pulse has a mild, moderate, severe weakness, and 4, 5, 6 is the PADL. Personal activities of daily living is a moderate, maximal, and total dependent. So for stage 5, his current at stage 5 is non-ambulatory, not bedbound, but the PADL is maximal dependent. For stage 6 is bedbound. So rehab goal and the rehab role in this MND case is to first we want to optimize the function of the pulse and maximizing the independence. Also want to minimize the disability, improve quality of life, address the possible impairments at various stages of disease, and to reduce the complications like lung infection and limb contractures. For the impairment, for our case, he actually has many impairments, but due to time constraint, we are asked by the organizer to focus on one issue. So the most important issue for this patient, his main concern is respiratory insufficiency. So focus on his main concern of impaired cough. The other respiratory part will be presented by our respi team. So our case here, he has his main concern is difficulty to cough. So cough is important to maintain a clear airway to prevent pneumonia. So the cough process actually consists of 3 phases, which are inspiratory phase, compressive phase, and expulsive phase. Started with irritant, then the pulse will have go to the inspiration phase, then compressive phase, and expulsive phase. For normal person, during inspiration phase, then the person will inspire the air into the lung, and then closure of the glottis will cause the build out of the intrathoracic pressure when the expiratory muscle is contract. So increase the expiratory muscle contraction will increase the expiratory flow rate, and sudden release of the air with the glottis open will result in an expulsive cough. For motor neuron disease, actually the motor neuron disease actually affects all the 3 phases, inspiratory, compressive, and expulsive phase. So inspiration for motor neuron disease for ALS, they will have a limited inspiratory capacity due to the inspiratory muscle weakness. Then compressive phase will be affected because of the weak glottis, and expulsive phase is because of the weak expiratory muscle causing the reduced expiratory flow rate. So this whole process is shown that it's important to have a good inspiratory phase to have the subsequent expiratory phase or expulsive phase. So peak cough flow, or known as a PCF, so it's used to determine the likely effectiveness of cough. So this is the modified one with a face mask and a peak flow meter. because our case here, the pulse doesn't have an adequate oral seal because of the oral muscle weakness. So we use a modified face mask to have better seal to prevent air leak from the mask. So there are two important values here. If the peak cough flow is less than 270 liters per minute, then means the pulse has inadequate airway clearance, and this requires intervention. For peak cough flow of less than 160 liters per minute is considered critical level of airway clearance, where he may require a trial of cough assist. So two important values here, 270 and 160. So the peak cough flow technique for our case, he actually used the modified one. You can see here the modified face mask and the peak flow meter to prevent air leak from the mouth. So ensure the pointer is set at 0, then hold the peak flow meter so that the fingers are clear of the scale and the slot. Then place the mask securely over the pulse mouth. Then instruct the patient to inhale deeply and then cough as strongly as possible. So we're going to take the best of our 3 readings, repeat 3 times and record the best score, the highest score. So there are different cough augmentation techniques to improve the cough effectiveness. So for our case, we'll focus on breathtaking. There are the methods. There are actually many methods. So the common ones are breathtaking, manually assisted coughing, and the MIE, also known as mechanical insufflation exsufflation machine or cough assist machine. So for our case, when we measure the baseline peak cough flow is 210 liters per minute. So he is less than 270 liters per minute. So he requires intervention because of less than 270 liters per minute. He also has a poor cough effort. So after we started him on the assisted breathtaking with lung volume recruitment bag, the peak cough flow actually increased of 52% to around 320 liters per minute and improved in the self-reported cough. These are consistent with the previous findings of the papers, improvement of around 50% if done correctly for the breathtaking. So what is breathtaking for cough augmentation? So the breathtaking is actually just basically means the pulse will going to stack one small breath on top of another small breath until the lungs are maximally filled, or we call maximal insufflation capacity. This the stone stacking at the beach is taking the breath. The analogy here is taking the one small breath on top of the another small breath until you can get a big breath here. So breath stacking is also referred as lung volume recruitment. So breath stacking is useful when the breathing muscles are weak and the taking deep breath is difficult. So by stacking a successive small breath, the pulse actually can achieve maximal insufflation. So by performing a maximal insufflation prior to a cough, will increase the inspiratory volume and will result in increase in the expiratory flow and the cough efficiency. So we want to understand the cough process. If the pulse has a good inspiratory volume, then we will also increase in the expiratory volume and increase the cough efficiency. So benefits of breathtaking, the most important one is increase the peak cough flow to clear the lung secretion. Then it also will maintain the maximal insufflation capacity, maintain the chest wall movement to reduce the contracture, mobilize the secretion, reverse the microatelectasis because it allows more air to enter the lung. And it also improve all the lung volumes and capacity, like tidal volume, battery capacity, and total lung capacity. So there are, for the breathtaking to improve cough, there are 2 ways. One is unassisted and one is assisted. Unassisted basically just without any equipment. So unassisted breathtaking, also known as glossopharyngeal breathing or gulping or throat breathing. It involves the oropharyngeal muscle, lips, tongue, and laryngeal muscle to push the air into the lungs. You can see here the patient is gulping, doing the gulping with the unassisted breathtaking. But for the unassisted breathtaking, it's actually limited in this case or in the pulse with poor glottis closure. Because a poor glottis closure will result in a difficulty to hold the breath and it's not efficient. So for in this case, because our pulse has a poor glottis closure, so it's not suitable for unassisted breathtaking. So we use the assisted breathtaking with a lung volume recruitment bag. This is a lung volume recruitment bag in view of the poor glottis closure. Because in this lung volume recruitment bag, there's a one-way valve. One-way valve will help the pulse to hold the breath during the breathtaking. So this is the set out of the bag. There are mainly three parts: the face mask, then one-way valve, and the resuscitator bag, also known as ampoule bag. So the one-way valve will allow the air to be inhaled in one way and help the pulse to hold the breath. The air only can be inhaled and cannot be exhaled. So some usual resuscitator bag or ampoule bag doesn't have this one-way valve. So make sure if you want to use for breathtaking, and there's a one-way valve so that the air can be inhaled and cannot be exhaled for the pulse to hold the breath. So how to do the assisted breathtaking with the lung volume recruitment bag to improve the cough in this case? So first, the pulse has to sit in the upright position here, and hold the face mask firmly to prevent any air leak from the face mask. Then when we squeeze the bag, then ask the pulse to breathe in and then hold the breath. The one-way valve will help with the holding of the breath. Then after that, we will squeeze again. Then the pulse will breathe in even more air. So breathe in and then hold the breath. So breathe in and hold the breath, total 3 to 5 repetitions until the pulse can feel a stretch over the chest, means reach the maximum capacity. So when they feel a stretch, the maximum capacity of the reach, then we will remove the face mask and ask the pulse to breathe out the accumulated air, then it will generate an effective cough. So this will complete one cycle of breathtaking. So breathe in and hold, breathe in and hold, breathe in and hold, breathe in and hold until reach the maximum capacity, then we will cough out. So these are called the assisted breathtaking. So the number of cycle and the frequency usually will decide by the doctor or therapist based on the difficulty of the lung secretion clearance. The usual cycle is 3 to 5 cycles, 2 to 3 times per day. But in this case, we ask the patient to do 4 cycles 2 times a day. If the pulse still has a weak cough, breathtaking actually can be accompanied by a manual assisted cough during the expiration phase. Because breathtaking actually target the inspiratory phase of the cough, and then the manual assisted cough is targeting the expiratory phase. So if still has a weak cough, then we can add on the manually assisted cough. Manually assisted cough, there are 2 ways. One is the abdominal thrust, and the other one is lateral costal compression. So this we have to call this one needs a carer or pulse, the caregiver, to perform a thrust and coordination with the cough to help with the expiratory phase of the cough. So for those pulse with the recent abdominal surgery, abdominal aneurysm, or acute bleeding ulcer, is not suitable for abdominal thrust, then they can consider lateral costal compression, where the pulse, the hand are placed around the lower rib cage and apply the pressure coordinating with the cough to improve the cough efficiency. So manually assisted cough, it actually will increase the velocity of the expiratory flow and sufficient to mobilize the secretion. So usually the pulse, they have weakened breathing muscle, so they cannot generate the expiratory force. So they use the manually assisted cough to improve the expiratory force. So in this case, our pulse in this case can generate efficient cough just by breathtaking alone. So no additional manually assisted cough is done by the pulse during exhalation phase. So the other cough augmentation method is the MIE, or known as mechanical insufficiency or cough assist machine. So the cough assist machine will simulate a natural cough by utilize the positive inhalation pressure, which is delivered gradually, then followed by a rapid shift in the negative exhalation pressure, and will stimulate a cough for the patient to cough out the secretion. So this usually is indicated if failed breathtaking or trial or cough assist if the peak cough is very low, less than the critical level of 160 liters per minute. Then cough assist machine is expensive. For our case, the patient actually is satisfied with the breathtaking with the lung recruitment bag, so he doesn't proceed to this cough assist machine because this one also expensive. So evidence for the cough augmentation in this case, there are actually some studies, some papers that show that the cough augmentation techniques and devices can assist with the secretion clearance. And the Rafiq et al. Also show that the regular breathtaking may be beneficial for individuals with early respiratory impairment. Clearly, et al. Actually show that breathtaking actually can increase the peak of flow significantly up to 30 minutes, not just in the means the peak of flow is not just improves immediately after breathtaking, but also can last up to 30 minutes. So a systematic review found that the breathtaking or the lung volume recruitment training is effective in improving the respiratory outcome measure, increase survival, and should be included in overall management of pulse. So for this case, our patient is actually satisfied with the breathtaking method for the secretion clearance. So he has actually no episode of chest infection. So it means quite effective until one day during the MCO. MCO means the movement control order period for the COVID. So during the MCO for the COVID, because of the boredom of he's bored of staying at home, he has this craving for his favorite chocolate drink here. So he actually is depressed with his new by mouth order, which is instructed by the speech therapy team in view of he has a severe dysphagia and already put in the PEG tube or percutaneous endoscopic gastrostomy tube here for the nutrition build up and the dysphagia. So he tried to take a sip of chocolate drink, but he has inadequate taste. He actually only because he didn't take any oral intake for the previously because of the PEG tube. Then we took a sip of chocolate drink, but he realized he has inadequate taste. Then he rushed and took a gulp around, according to him, 1/4 cup or 60 ml to try to test the chocolate drink. But because of a lot of amount here, a lot of quantity here, he actually choked and panicked. Then he developed shortness of breath and fever, and then sent to hospital and treated as expiration pneumonia. So in this scenario, the case deflection is the question we had to ask is how to satisfy the pulse craving to improve his mood and quality of life, and at the same time to prevent the expiration pneumonia. And because this patient has dysphagia, but he is craving for the chocolate drink. So how can we satisfy the craving and at the same time prevent expiration pneumonia? So for just now, that scenario, that case, the patient actually has a perceived reduction of taste. He realized he has impact taste. So perceived reduction of taste actually is reported in ALS patient, but in particularly the enteral feeding group, means the non-oral feeding group. But the exact cause is unclear for the impact test. So the impact test can be distressing and can affect the psychological aspect and quality of life. So for like in this case, the patient has dysphagia. So the alternative for the new by now is there's a concept or a method called test for pressure. Test for pressure means we actually dab the patient's favorite taste to the tongue without actually swallowing the drink. Just dabbing for the testing without swallowing food to prevent any expiration pneumonia. And the paper also mentioned that the regular stimulation of taste bud could actually possibly avoid the worsening of impact test over time with a possible rehab effect. But further studies are required for the impact test in the motor neuron disease. So how do we do the test for pressure for those dysphagia group? So first we have to ensure the mouth is sufficiently clean, and we can use a non-flaying gauze which wrap around the spatula. So this is a non-flaying gauze because the flaying part might cause expiration pneumonia. Then we dip and dab. We dip to the patient's favorite flavor, like chocolate drink, like in this case, or coffee or orange juice. Then we take away the excess fluid. The concentration had to be appropriate to the extent that the patient can taste. After we dip, then we dab to the tongue, so the pulse can taste the flavor. Then repeat as often as required or appropriate. Then we have to maintain the oral care or oral hygiene. So for this case, the pulse is actually satisfied with the test for pressure, and he can test his favorite taste of chocolate drink in a safe manner without causing expiration pneumonia. But the concentration of the chocolate drink actually is higher compared to previously to have to achieve the similar test as the pre-morbidity. Means the patient has impact test, so it requires a higher concentration of the chocolate drink to have the similar test as pre-morbidity. But overall, he has satisfied with the test for pressure, and it has improved mood and quality of life. So happy pulse and happy cows. So case reflection and main learning points. There are two main learning points here. The first is the impact cough can be distressing, so can possibly lead to morbidity and mortality like pneumonia. So breathtaking for this case can be used as a low-cost first-line intervention for the lung volume recruitment and cough augmentation in ALS. So the breathtaking with the ambu bag or the lung recruitment bag is cheap and these are low cost and can use as early intervention for the cough augmentation. Then secondly, the impact test can be distressing and impact the patient's psychological status and quality of life. So for those dysphagia group, we can consider test for pleasure as an alternative to new by mouth. And because the test for pleasure can actually improve the psychological status and quality of life, and at the same time it's quite safe, and it is conducted in a safe manner to prevent aspiration pneumonia. And the paper also mentioned that the regular test stimulation with flavor in a safe manner could possibly provide a test rehab effect. Means improve the test, improve the impact test, but this further studies are required. It's just possible test rehab effect, but further studies are required to show any improvement in an impact test with regular stimulation. So these are my references. Okay, I have finished my presentation. Thank you.
Good morning, everyone. Welcome to Sarawak. Thank you, MND Beyond Border, to inviting me to give this talk. Probably mine is not as technical as previous two speakers, but bear with me if there are a lot of jargons of the ventilators words that we go on. Yeah, okay, let's go start. Yeah, this is just the outline of my presentation. ALS is a progressive neurodegenerative disease that affects all the respiratory muscle. And we know that pneumonia and progressive respiratory failure are the leading cause of death and occurring 3 to 5 years of diagnosis. And one more thing that not commonly noted in the previous speaker is that sleep disorder breathing actually is common among this group of patients. So we know ALS affects all respiratory muscle. Inspiratory muscle weakness, expiratory muscle weakness, and the bulbar weakness, at which Chai have mentioned a lot about it, and about the dysphagia, dysarthria, and leads to aspiration and pneumonia. And what about our inspiratory and expiratory muscle? When you have a weak inspiratory muscle, you have reduced lung volume, and then you become dyspnea, and because it leads to all restrictive lung disease. Expiratory muscle weakness, you have poor cough, and then we have poor slow speech, and then you have mucus plugging. Also, this leads to respiratory failure. So when the patient approaches, mainly is from the referrer, that we actually ask symptoms and signs and look at the signs related to respiratory muscle weakness. Patient will tell you dyspnea with exertion, optopnea. This is the first most important question I'll ask whoever patient that come to me with an MND. And because this is, you will decide on your treatment sooner or not. Of course, other symptoms suggestive of hypercapnia like morning headache, poor sleep can be due to sleep disorder, breathing, and other causes, daytime somnolence, weak cough, and the poor bulbar symptoms. So when you see the patient in front of you, of course, beyond all the neurological signs, you can see the patient using accessory muscles for breathing, paradoxical abdominal movement, patient become very tachypnic. And then when you look hard, you don't need to look hard, you look at the patient and say the chest wall actually doesn't move much. Basically, we do a pulmonary function assessment to look at how is the respiratory muscle strength. So it's commonly available is spirometry. And then, or in your lab, is a more advanced lab, you can get a full lung function that can do the lung volumes and also the DLCO. But the basic spirometry, you can get the vital capacity. This is what we widely use to assess the muscle strength. So can give you some idea what's going on, and also the MIP and MEP. The positional testing is helpful as well, especially it's easily done and not that difficult for patients who have difficulty doing a very hard expiratory flow later. And I know in the guideline they tell you about SNF, phrenic nerve stimulation assessment. To be honest, I don't think it's available in Malaysia. Phrenic nerve stimulation available in my previous center in Perth. It's also very research-based kind of investigation. So let's go back to what happened when the patient of MND in the pulmonary function. The diagram on the right side here is just for the reference so that you recall of your pulmonary function parameters. So I bring you all back to the vital capacity that I'm focused on, which is the combination of IC is the inspiratory capacity and ERV, expiratory reserve volume. In a normal person, you can see that it's about 5 liters. So even so, when a patient, NMB patient, before the lung volume, the total lung capacity drop, you can see actually the vital capacity actually been reduced already. It got worse as the patient lie down in a supine position and getting lesser when the patient is supine and sleeping. Yeah. So that's why we, when you read about MND assessment of lung function, it's always the vital capacity. So what are the measurements that actually that signify that muscle weakness? So different guidance or different recommendation have different threshold, but overall there's a between 50 or 80% reduction from the predicted vital capacity. You take it as a there's muscle weakness. And then when you do a VC in a different position from sitting to supine, that drop more than 20%, that is suggestive of diaphragmatic weakness. And there is more than 40% drop, means it actually suggests that both sides of your diaphragm actually is weak. MIP, we do it in our hospital as well. So it's a simple test that your patient blow over a clotted and occluded valve, then you can check the pressure. So if the patient has less, there's still different threshold. Again, between 40 to 60. If anything less than 40, actually the patient is high risk of hyperventilation. So some guidance to tell you that you can use a SNP as well, but it's not available in Malaysia, I think. Sleep disorder breathing. So I briefly bring you through. It's frequently overlooked, but it's actually is relevant to our patient, especially in the ALS patient. So a patient can present it with obstructive sleep apnea due to their neurologic cause and underclinical cause causing the obstruction. And hyperventilation is common among this group of patients because of the low lung volumes, reduced response to the due to hypercapnia due to weakness. And then pseudocentral, I will explain more about that later on, because this you find it in some of the sleep study is directly due to diaphragm weakness. And some patients you'll find some chain stroke breathing as well. Yeah. So yeah, there are a lot of ways to diagnose sleep disorder breathing, and depends on the vulnerability and how reliable it is. From nocturnal oximetry, you can do the carbon dioxide monitoring at home, whether it's either end-tidal or tricutinous, respiratory polygraphy, which is available in my hospital, and also polysomnography. Just bear in mind that you do not need a diagnostic sleep study test to diagnose for this patient, especially if you know this patient has respiratory muscle weakness, you are going to start treatment already. A PSU usually reserved for a very unusual case that you need to detect other sleep disorder beyond sleep disorder breathing. This is an example of what we call it pseudocentrals. And actually this example, when you find that the patient had diaphragm weakness, suggestive of diaphragm weakness, then you see a sawtooth desaturation during your overnight nocturnal oximetry. And if your colleague ever show you a PSG of a patient with a diaphragmatic weakness, you can see in this patient in the REM sleep that the flow, it means the flow of the air actually reduced, and then the chest excursion actually reduced while the abdomen excursion is still present. So actually this we call it pseudo-central events at PSG. It's actually a sign of diaphragmatic weakness as well. Yeah. Hypoventilation is, like a previous slide mentioned, is part of the sleep disorder breathing of ALS. So it depends on what kind of definition you use and then availabilities. So it's actually basically measuring your SpO2 or CO2. Yeah, different guidelines give you different recommendations. So all are being acceptable. And then if the patient fulfill either one of it, he had hypoventilation, and then you need to treat it. So now let's go to the NIH treatment. So I think this paper changed the landscape of treatment of patients with respiratory impairment in ALS. In 2006, a Newcastle study that showed that you give NIV, patient with a moderate bowel impairment have improvement in the survival and quality of life up to 7 months. But however, that time they said the severe bowel involvement doesn't have benefit much from the survival, but only quality of life. Okay, this is about 15 years ago. So another study in Australia, so they show that actually this is not an RCT because you cannot do any more RCT beyond that 2006 because this is such a landmark paper. So they actually proved that in their cohort, even the patient with bulbar involvement, severe bulbar involvement, they actually had beneficial survival for up to 19 months if we are giving an NIV. The question is like, when you want to start the NIV? So the major guidelines, the NICE, the Canadian guidelines, they actually give you a list of when you can start it based on your investigation, like your arterial blood gas, your lung function, your symptoms, or oximetry. So this is just a guideline, but they also depends on your patient, that you assess your patient's symptoms and then you complement it with this investigation, then you can make a decision when to start on the NIV. So I think the spirometry will be done in most of the patient when you first presented to a neurologist, then you will get a rough idea what the vital capacity is. And then usually if the request of a respiratory muscle assessment, we will include a MIP and MEP assessment as well. So you'll get the result from us, what is the respiratory muscle strength. Oximetry, it depends on the availability of the center. And in my center, I don't usually do it, but if needed, I can do a polygraphy actually that which have the oximetry to delineate the desaturation. Yeah, and then ABG we frequently do for patient as well as a baseline. It is nice actually give a very good recommendation on how you want to start and how you counsel the patient. Of course, before you start, you talk to the patient first and the carer as well. Both are very important person. And when you need to initiate this topic of NIV, actually there are no definite period. Actually, when you have diagnosed the patient, you can start to discuss about this NIV. And then when you are monitoring the lung function, they said there's some, they said the reason of that you monitoring, you want to decide on the future treatment. And then of course, when the lung function deteriorate, so you need to discuss of this NIV. Yeah, but you have to put it in a very sensitive way. Yeah. So when we are giving a counseling for NIV, right, you have to tell them what is the reason of giving it, because to improve their symptoms and also can be life-prolonging from the previous studies. And reassure patients that they can stop the treatment anytime. It's not like they must do it all the time and tell them that they can get any help whenever they don't feel like it and they're uncomfortable a bit. Yeah. We offer trial of NIV. Let's say the patient is already fulfill the criteria to start NIV. We offer the trial of the NIV therapy. So the patient, you can either start it, commonly we'll start it as an outpatient because it's easier and due to bed availability as well. And then you get the patient accustomed with the therapy. So usually during the day when the patient come here, we put the patient on the NIV on the certain settings for the patient and get them have a feel of some air blowing to their face with the aim the face on their face first. So slowly you look at the patient. And then after that, the patient get the feel of it during the clinic. Then you let the patient go home with the device and then they use it at night and then during the sleep as well. And gradually they will increase their hours. And the most important thing about starting an NIV trial is early review and troubleshooting. If your patient you started and never follow up after 1 or 2 months, your patient probably will not going to take the therapy in the future. So my practice is I always see them back within a week to check for any problem. And I also give them contact number. Let's say they use the machine. The next the night they cannot tolerate, I ask them to give me a call back. I will see them back the next day to make sure what is going on. Yeah. So some of the proposal setting from the other guidelines that you started the pressure usually we use the pressure support mode and then we start it low and with some backup rate as well. Yeah. And interface. And NIV treatment and interface are interrelated and it's a very important subject. So you choose the correct interface that's suitable for the patient will be able to accept the treatment well. So commonly used is oral nasal or nasal mask or nasal pillow in our setting. Yeah. So, and then when you put the patient on the interface, it should not cover the eyes or lips. So it means you should appropriate fitting it. And then when you put the patient on the interface, not, you should let them try on the interface with different posture. Let's say the patient already very weak trunk and then weak head support, so they probably lie down on one side with the most of the time. So you need to put the patient on the NIV with the mask in that position to see whether it's fitting or not. It's not just put there when the patient's sitting with the support, you put it, and then after that, that's it. So, and then sometimes you have to check the patient, put an NIV with the mask in the supine and the sleeping position. So you test everything, the fitting is good, the leak is not good, only that is considered a good fit. Yeah. So bear in mind, NIV is also come with complication. Mouth leak is very common, especially if you are using a nasal mask. And then this will lead to dry mouth, poor ventilation, and then the sleep will be disrupted. One of the ways to help it is you can use a chin strap. And then pressure sore is common, especially when your patient is using the NIV more and more, longer and longer, like more than 12 hours. So if your patient is using more than 12 hours, it's good to suggest to change the interface type periodically. Yeah, you don't want to end up like this photo, the patient like this photo. Yeah. So, and there are another thing is besides the interface related complication, we have settings related complications, like they have a lot of asynchronous, ineffective effort triggering, etc. This information, actually you can get it when you turn it on and you look at the graph at the machine. But this one a little bit heavy, but usually we have to look through this to see what's going on. Yeah, if the patient have asynchrony, we have to troubleshoot it early to avoid any other future complication. Yeah. So there are other causes that is non-ventilatory cause that causing the NIV failure. Dr. Chai mentioned the patient can have a lot of bronchial congestion and then impaired cough. So a lot of secretion pooling at the oral cavity. So it can cause excessive cough, excessive salivation as well. And then we make the patient very difficult to breathe. And then your patient, as the time goes by, become, because of the swallowing problem, under nutrition, and then the face becomes smaller. The mask fitting may not be too great as the time goes by, and then leads to a lot of mouth leak as well. Yeah. So let's go to Mr. A. I think Dr. Jason and Dr. Chai explained a lot of his demographic already. I just talked briefly about his presentation to our clinic. So he was referred to a respiratory clinic back in August 2019. So the documented presented symptom that time already bilateral lower limb weakness, dysphagia, and optopnea. MMRC was 4 during presentation with bulbar speech, right tracheal deviation, and reduced chest expansion. So some baseline investigation was done during that time. The blood gas already shown that there is a compensated hypercapnia failure. And spirometry, that point of time, show moderate restrictive abnormalities. Even 2 months down the line, actually it's not too bad. The FVC is still holding on there, but the MIP actually is less than 40, minus 28. And this is the only graph available from I get for his spirometry. Like you can see here, actually he can't do a complete blow at the end. So, but this is his maximum effort she can do for the spirometric test. And my colleague that time actually did a peak cough flow for him. It's only 170 liters per minute, and a baseline ESS was checked that time was 8. So he was subsequently started on NIV therapy since November 2019. He was using oral nasal mask, and I seen him when I first met him back in May 2020. So I look at him and then he complained of dry throat. So I look at his data, there was significant leak due to a nasogastric tube. So I refer him to the surgeon for the PEG tube after counsel him the indication, the risk, and then because I also had significant bulbar involvement. So and he agreed for it and had the gastrostomy done in 2020 and the mask leak improved. So I'll show you the timeline of his NIV therapy. He was started on some volume assure setting initially, but also there's some significant leak that point of time. I attribute it to the NG tube, and also probably the setting may not be too appropriate for him at that point of time. But this percentage trigger means how frequent the patient can trigger the machine to deliver the breath, the pressure. So as you can see, as the time goes by, he cannot do the job himself, and the machine have to do it for him already. He cannot trigger the machine. And the usage is actually getting longer over the years. And in 2021, he actually deteriorate rapidly. Yeah, and the usage is getting longer, and the leak is very stable. I would say that after we had get him a gastrostomy, and unfortunately, he got admitted somewhere end of last year for aspiration pneumonia, and he become more tired, and then he needs to use the machine most of the time, and then he become more sleepy as well. Yeah, and then because he's using a machine that has give us a lot of information, so the more of the time I don't need to do a blood gas or a lung function to denote what's happening to him. So this is what I got from his last visit to my clinic. He's on a 16:6 setting, and then I set at the rate at 16, and it's all the machine trigger ventilation. The leak is not too bad, and then because I can see that in the overall the leak is okay, the sleep apnea index is good, everything for his NIV is so far so good for him. And then I can day by day analysis of his data also pretty decent as well. Yeah, fortunate for him, for his NIV, he doesn't have much of the issue of like source, pressure source. Like the leak was initially was actually quite well compensated by the machine. He tolerated it quite reasonable, okay after the adjustment. Yeah, so but I think he probably, looking at his progress of the data, I think he probably needs longer than 12 hours of NIV treatment very soon. Yeah, I think that's all for my presentation. Thank you.
Good morning, everyone. I'm Angel, Palliative Registrar from Radiotherapy, Oncology and Palliative Unit, Sarawak General Hospital. Thank you for the opportunity given to share on this platform. Today, I'll be sharing on perspective of palliative involvement with an emphasis on person-centered care approach in MND. And in this case, it would be Mr. A-centered approach. But before I begin, here's a little food for thought. If you had only a few years to live, would you want to know you are dying? Would you want to make your own medical decisions? And if you can't make decisions for yourself, who would you appoint as a surrogate decision maker? And in this case, who should make medical decisions for Mr. A? As I begin, let me introduce what is palliative care. Palliative care is an approach that improves quality of life of both patients and also families who are facing a life-limiting illness. It prevents and relieves suffering through early identification, appropriate assessment, and treatment of pain and other problems encompassing physical, psychosocial, and spiritual pain. Here, I'll highlight the involvement of palliative care in patients with life-limiting illness. Let's observe the figure above on the older landscape model of palliative care, or also termed as care at brink of death. As the name states, traditionally, palliative was often involved with patients in the later stages of disease, particularly during the dying phase, as highlighted in turquoise. In this model, by the time palliative team is on board and patient is dying, we are pretty much limited to managing end-of-life symptoms with the limited knowledge of patients' value, hope, and preferences. Now, let us focus on the newer landscape at the bottom. You can see that there is a shift in involvement of palliative care as opposed to the old model. Palliative care is introduced to patients earlier, and it can be as early as at diagnosis of a life-limiting illness. Active involvement may be minimal at the beginning, but as the disease progresses and symptom burden increases, palliative involvement would increase with time to help improve their quality of life through managing of symptoms, discussing of goals of care, and what is important to them when disease-modifying treatment are seen to be futile or ineffective. Certainly, palliative care plays an important role towards end of life or the dying phase and can continue on with bereavement support. I want to also highlight, while palliative team is on board with patients' care, it is also essential for primary physician to continue to support and provide their expertise and maintain a patient-physician relationship throughout the course of disease trajectory. This prevents patients or family members from the feeling of abandonment and facilitate closure of an important therapeutic relationship. MND, as we all know, is a life-limiting illness, and early introduction to palliative care at diagnosis would certainly benefit patients and carer greatly. Early involvement increases the ability for patients to express their concerns and goals of care before their illness becomes too advanced. MND patients' palliative care needs may vary through the disease trajectory, and the involvement of the team may be episodic, occurring at times of change, crisis, or decision-making. For example, palliative care may be more involved at diagnosis, when gastrostomy is discussed, when respiratory function is declining and NIV is discussed, when there are cognitive changes, and certainly at end of life. There may be periods between these events where the need for palliative care reduces and the multidisciplinary team can continue to support both patients and their family. In Mr. A's case, while he was diagnosed with MND in August 2019, we started seeing him very soon in the following month during the first multidisciplinary team clinic. Here's a brief background of Mr. A, who was previously working as a police bantuan at Petronas. He is married with 5 children, currently living with his 4th son. His wife is his main carer, who has been most supportive of Mr. A's decision-making. She's very hands-on with his care and excellent support as his disease progresses. She accompanied him for and is coping fairly well. Due to work commitment, his children were not able to be there for his follow-up. Now, no one likes being a bearer of bad news, and in this case, during our first encounter with Mr. A, we used spikes as a communication framework. Despite suffering from dysarthria, we were still able to have a meaningful and empathetic conversation about his illness and what is important to him. Our setup was in an outpatient MND MDT meeting in rehab clinic. A private room was available to minimize distraction and interruption, maintain privacy, and to provide a safe place for Mr. A to ventilate and express. He was accompanied by his wife, who was there as a carer and to provide support. After introducing myself and the work that my team does, I explored Mr. A's perception in regards to his disease, and to my delight, he was comfortable and eager to discuss about his disease. He was able to reiterate his diagnosis, understanding that it is an incurable disease, with fairly good understanding on the role of Riluzole. On invitation to discuss further, Mr. A was very keen to know more in depth on possible progressions and complications that may entail. This goes to show that albeit the poor outlook of disease, patient wants to be in control. They want to know and plan their life. Many physicians find discussing disease progression uncomfortable, difficult, and even more difficult to deal with emotions that comes with it. However, studies show that most patients want to know if they have a life-limiting illness, they want to know their prognosis, and they would want to know if they are dying. We managed to discuss possible progressions and complications in bite-sized information and ways to help manage his symptoms. In view of a few early signs of dysphagia, dysarthria, and reduced effort tolerance, he was introduced to communicative tools, feeding tube, and NIV briefly. His emotions, which were appropriately set, was addressed, and his biggest worry and concern was leaving his family behind. What was most important for him was managing his symptoms well and to spend quality time with his family. I find this comic very relevant in our practice. Sometimes, even if I stand in the middle of the room, no one acknowledges me. I believe many patients can relate to this, and even more so in our MND patient population, where conversations are often felt to be more convenient to be carried out between physician and caregivers rather than patient themselves. The sentiment in this comic is not an uncommon scenario. We have seen patients on wheelchair being pushed into clinic room, seated right in front of healthcare worker, but their presence are not acknowledged, and the focus is placed on caregivers where they are often bombarded with questions pertaining to the patient's symptom when patients themselves are still communicable. Physician expects caregiver to tell them if patients have pain, where the pain could possibly be, whether he slept through the night as if caregivers will watch guards through the night, or if he feels fresh upon waking up. More often than not, caregivers can only give their perception of patient's pain. In fact, it might not be an actual representation of their pain. Yet, there is still a tendency to believe caregivers rather than the patient themselves. Now, putting ourselves in patient's shoe, is this the kind of clinic you would look forward to attend, where your presence is not acknowledged? Your true needs are not adequately explored and managed. Your fear and doubts not addressed just because no one acknowledged your presence or asked you because of the lack of communicative skills as a result from dysarthria. This sort of scenario are definitely one which we really need to be mindful of and to work on improving, because our duty of care is to our patient, not carer, unless patient is absolutely non-communicative and have appointed a surrogate or spokesperson on his or her behalf. No one appreciates having decision made for them without their input. Now, moving back to Mr. A's story, as his disease progresses, he was receptive and on board with the suggested treatment options, and he was keen for PEG-tip and NIV. His symptoms were very much improved with the recommended management by the MDT team. His wife was also seen to be calm and on board with his medical decisions. MDT team supported him through prescribing of appropriate equipment, symptom management, and NIV titration. While Mr. A may be someone who is receptive to suggested management options, not every patient shares the same goals and values as Mr. A does. Palliative care emphasizes on person-centered approach as opposed to the commonly practiced disease-centered approach. Hippocrates said, "It is more important to know what sort of person has a disease than to know what disease a person has." A person-centered approach of care is providing care that is respectful of and responsive to individual preferences, needs, and values, and ensuring that patients' values guide all clinical decisions. It is a care provided beyond their disease and tailoring our service to suit patients' individual wants and needs. It is about respecting that they have their own views on what's best for them and have their own values and priorities in life. Person-centered care approach demands a cultural shift from healthcare worker from the routine practice of disease-focused care, and it is essential to get to know a patient as a person and actively involve them in care-related decisions. What is important to physicians, which is usually health outcomes, may not correspond to what is important to our patients in accordance to their personal value. Pain, for example. How would a physician respond to a patient's pain? Prescribing of painkiller to alleviate the pain. But if physicians can consider asking further questions on how does the pain affect their living, you might be surprised. One might tell you, having some amount of pain helps them feel that they are alive. Can you see how sometimes our values may not be the same as patients' values? Hence, in order to deliver a person-centered care, it is important to be curious and to explore patients' values, which will provide the best guide and decision-making. Outcomes from patient-centered care includes improvement in health with better recovery from their discomfort and concern, fewer diagnostic tests and referrals, better emotional health and adherence to treatment. Person-centered approach enables patients to retain their dignity and autonomy during an already challenging time. The patient will feel like they have greater control of their life. We all like to be in control of our life situations, don't we? What is important to you? What would you do if you are unable to swallow? What would you want if you start losing weight? What would you want if you cough on swallowing? And what would you do if you start having saliva drooling? While we know weight loss and dysphagia are poor prognostic indicators for patients with MND, must all patients have a feeding tube? Have you ever imagined what it's like to have a feeding tube on your own body? The care that entails, the possible complications, the body image, how having a feeding tube might affect your daily activity. How long do you think it will take you to consider and respond to a suggested treatment as such? Would you be able to make a decision over a 15 to 20 minutes consult? Can a patient refuse feeding tube? Would you feel distressed having a patient who refuses feeding tube? What about NIV? Similar questions. What do you want? If you have 2 to 3 years to live, would you want BiPAP support? Would you want intubation with tracheostomy? Is living on ventilator something you would consider? And can patients refuse NIV? How comfortable are we in managing patients who understands their disease and chooses to decline feeding tube or NIV? Do we label them as difficult or challenging patients? Or do we see it as a failure from our side in counseling patients? With these questions in mind revolving around decision-making, I would like to introduce a central feature to a person-centered approach, which is shared decision-making. Shared decision-making is a conversation that happens between a patient and clinician to reach a healthcare choice together. It is not paternalistic, the doctor knows best model, where physicians believe that they know what is best for patients, and the physician makes critical choices and tell the patients what he or she believes the patient needs to know. You are losing weight, you'll need a PEG tube, and I'll refer you to the surgical team for a PEG tube. And in our local setting where most patients are not very vocal and are very compliant patients, they will probably just nod without understanding, and the next moment you know, they have a PEG tube to deal with. While shared decision-making is not paternalistic, neither is it an informational relationship where physician shares information but then leaves the individual to supply a decision for themselves given all the facts and figures. Shared decision-making is when physician shares information, but at the same time offers guidance and support to help patients come to a decision they are happy with. It is important that after providing sufficient and accurate information, we assess their understanding, allow patients and family to ask questions. And only once understanding has been achieved, we can then discuss care options, assist patients to make decisions, and most importantly, respect their decision. In order to assist patients to make decisions, physicians can ask patients, what do I need to know about you as a person to give you the best care possible? Or other ways of reframing them to help you know what is important to them. Are you the same person you used to be? And if not, how has that changed? Do you feel you are in control? Have you lost your place in life? Is there anything you are looking forward to? What are you proud of? And what are you worried about? What do you worry about? I want to recommend an essential and insightful international bestseller book, which I think every physician should read in the course of their career, written by Atul Gawande, entitled Being Mortal. He is a renowned surgeon, writer, and public health leader. In this book, he writes on his personal reflection on dealing with aging, death, and dying of his own family members and patients. And he talked about struggles of his professions when faced with death and dying. Reading his book brought about changes in my perception and practice on how we see patients as a person beyond diseases, beyond diagnosis and organs. He is an excellent writer and he writes from a perspective of a doctor on death and dying, which makes it easier for us to relate to. I like how Atul Gawande reminds us that while to most doctors, purpose of discussion about terminal illness is to determine what people want and the focus is on laying out options. That's a mistake. A large part of the task in discussion about terminal illness is to help people negotiate the overwhelming anxiety. Anxiety about death, anxiety about suffering, anxiety about loved ones, anxiety about finances. There are many worries and real terrors in facing a terminal illness. This book provides a bigger picture on how people need to be informed and supported when making decisions about their health and their lives. And he calls for a change in the way medical professionals treat patients approaching their ends to focus on well-being rather than survival. Discussion on end-of-life care is a topic, though may be uncomfortable to many healthcare workers, but it is perceived as an important topic for patients in order to actually help them to prepare for the eventuality. Patients with MND have particularly complex care and support needs in final stages of life. But evidence from many studies is that death from MND can be peaceful when there is palliative care on board. The common discussion topics revolves around discussion on preference of place of care and death, provision of anticipatory medications, and advanced care planning. If there is anything I learned from Mr. A, it would be the impact of multidisciplinary team involvement in the care of a patient, and the impact of a person-centered approach despite the limited communication. Working with patients in a more person-centered approach does place new demands on healthcare workers, and it requires excellent listening, communication, and negotiation skills, and the capacity to respond flexibly to individual needs. Communication skills and empathetic responses can be improved and cultivated with practice. Effective evidence-based medicine is central to what most patients want, but person-centered care cannot be reduced to technical papers published. Guidelines and protocols have their place, but they must not be allowed to squeeze out the crucial human qualities of caring and compassion, which are highly valued by patients. The biggest barrier to person-centered approach is probably culture. And I hope that through today's sharing, you will see a new light in managing MND patients, and perhaps pause and ask, what do I need to know about you before we discuss how to manage your illness? Communication is an art, and if done well, can influence people with empathy. I would like to end with a quote from Patch Adams. You treat a disease, you win, you lose. You treat a person, I guarantee you'll win no matter what the outcome. With that, I end my talk. Here are some of my references. Thank you very much.